This is interesting. There's data at ASH looking at the dual co-stimulatory molecule CD28 and 4-1BB, and then it's early. Study from Germany, and there's several trials looking at this, and where the CD28 typically is probably believed to be more for the early amplification, and the 4-1BB for the persistence. So they had less toxicity than expected, promising small number of patients, but promising data. And I think understanding better on how we do this construct will be very critical. There's CAR-T combined with a cytokine and ARM CAR-T and all that, but there's also something that might be easier and more promising given the complexity, the cost, is the off-the-shelf CAR-T. Dr. Medak, what do you think?
Yeah, I mean, I think that the ability to do that would take away some of the waiting time and
Sure.
be helpful for that, because if you could just give it to a patient like you give them another treatment, it would be, decrease the time to treatment, be better for not having delay, be better for patients with aggressive disease.
Dr. Chavez, what do you think?
Yeah, I think allogenic CAR-Ts are another kind of alternative to cell therapies, and I mean there are currently several trials looking at it, and as I mentioned, usually the turnaround is shorter, so it's available, so you can just start the patient. As an example, I had a post-CAR-T patient relapse, and I was trying to enroll on any available trial I had. I couldn't because, you couldn't get them in. But the allogenic CAR-T, actually, I was able to get him in, and he's going to be treated next week. So I think, having that advantage of not waiting for 4 weeks or 3 weeks to get treated is a positive thing for allogenic CAR-T, and it's something that is coming into play. The other factor is that, these CAR-T cells are coming from healthy volunteers, and they have probably the better T-cell repertoire. They're not as exhausted. Probably you can manufacture better CAR-T cells from those volunteers.
So what becomes of transplant? Nathan.
Yeah, I think that at least, especially allogeneic transplant, I see this as really a very, very limited role now in large cell lymphomas. Mm-hmm. Autologous transplant, and I think we talked a little bit about ongoing trials where they're trying to randomize patients to standard transplant at relapse versus CAR-T. Although that sounds like a great idea, I think we always have to remind ourselves that autologous transplant is curative in about 50% of patients. So that data, we don't yet see that data in CAR-T, right? The long-term cure rate with CAR-T cells is probably on the order of 30%. Now the hope is when we move these CAR-T cell products earlier in lines of therapy, then that's going to be better than what we see with autologous transplant. But again, to be the devil's advocate, we have not seen that chemosensitivity is really a predictor of outcome with CAR-T. So it's a bit of a gamble whether or not these will replace autologous transplant, but they're ongoing randomized trials, and we should know the answer.
Immunotherapy, obviously, the CAR-T is ultimate immunotherapy if we want to. The first immunotherapy was allotransplant, right? Yeah. And the real immunotherapy, but there's a lot of other ways to do this. The checkpoint inhibitors in lymphoma outside of Hodgkin and primary indiopharyngeal have not been really convincing, right? So in large cell lymphoma, even in combination with EP-Nivo, this is not a very high. So their strategy is trying to build up and combine with small molecule IMiDs or targeted therapy. And then what do you think, Greg? What is appealing in that setting of combining with the checkpoint inhibitors?
I think you're exactly right. The single agent activity of checkpoint inhibitors is not looking as good in non-Hodgkin's lymphoma, diffuse large B-cell lymphoma, or even follicular lymphoma, as we've seen in the Hodgkin's lymphoma. And this is somewhat surprising because if you look at the microenvironment, it's obviously very vibrant. We look at the number of cells, and the effector cells appear to be there, yet it doesn't necessarily correlate with what we see in the clinic. So what a lot of people are trying to do now is to basically alter this microenvironment and try to mobilize those immune cells to be actually inducing immune response against the tumor. HDAC inhibitors here are looking quite interesting in terms of modification of PD-1 and PD-L1 expression and microenvironment. Obviously, IMiDs, we've been long-standing interest in this space and also being considered. Although in the studies with myeloma, we've seen some toxicity, which put I think, temporary hold at least on some of those concepts. So if you look at the preclinical study, there are a number of small molecules which can actually modify the immune response of microenvironment, and then the logical combination for this would be to combine them with PD-1 blockade.
You guys had a study looking at acalabrutinib and pembro in large cell lymphoma and eligible for transplant, and I don't remember all the detail, but I think there was some very durable response.
Yes, we actually have seen quite durable responses in patients, heavily pretreated patients with diffuse large B-cell lymphoma. And with the doublet, it's sometimes difficult to differentiate the effect of BTK inhibition versus a combination. However, typically we do not see such responses with BTK inhibitors as well. So it's definitely one of those very promising strategies where the BTK impact on the immune compartment could actually help the PD-1 blockade to affect the tumor growth and eradication of immune therapy.